conectarse con esta conferencia, autorizan el tratamiento de los datos personales que serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra política de datos personales, la cual pueden consultar en www.cardioinfantil.org. Igualmente les informamos que esta conferencia está siendo grabada. Está habilitado el chat de preguntas en la barra de participantes. Les agradecemos dejar allí las inquietudes para resolver al final de la sesión. Doctora María Juliana.
Bueno, buenas tardes a todos. El día de hoy tenemos el honor de contar con la participación como expositor del doctor John McMurray. El doctor John McMurray se formó en Medicina y Cardiología en Manchester, Edimburgo, Dundee y Glasgow y fue nombrado cardiólogo consultor. Actualmente es profesor de cardiología médica y subdirector del Instituto de Ciencias Cardiovasculares y Médicas de la Universidad de Glasgow en Reino Unido. Es miembro de la Sociedad Europea de Cardiología y del American College of Cardiology y de la Asociación Estadounidense de Cardiología. Bienvenido, doctor McMurray. Dr. McMurray, we are very pleased having you here with us discussing this amazing topic. Go ahead.
Well, thank you. Somebody's unstopped me sharing my screen. Just let me go back. So, are you able to see my slides?
Yes, doctor.
Thank you very much. Just make sure they're working good. Okay, well, thank you very much for inviting me to speak at your meeting. It's very dark and very cold here in Glasgow tonight in the middle of winter, so I'm sure it's much nicer in Colombia. I'm going to talk about the treatment of heart failure with reduced ejection fraction, and actually I'm going to change the title, as you can see here, a little bit. In fact, I'm going to talk about moving beyond neurohumeral blockade as an approach to treating heart failure with reduced ejection fraction. And as you will see in a few minutes, there's really been two steps forward, which I will discuss in detail. So these are my disclosures. My university's paid for my participation in clinical trials. So let's look at the first step beyond neurohumeral blockade. And that was really with the Paradigm Heart Failure trial, which is now 6 years old. And that was a step forward beyond neurohumeral blockade, because what we were doing here was still working on neurohumeral systems, but we were actually trying to stimulate or augment one system rather than block systems. And we tried to do that by inhibiting an enzyme called neprilysin. And the reason we wanted to do that is because this enzyme breaks down natriuretic peptides produced in the heart, the blood vessels, and the kidneys. These are really the body's own defense against pressure and volume overload. If we inhibit this enzyme, we prevent the breakdown of these peptides and we increase or augment or stimulate the natriuretic peptide system. So after about 25 years, believe it or not, of trying to work out how to do this, we eventually showed that we could do it using this combination preparation, sacubitril/valsartan, or maybe it should have been called valsartan-sacubitril, a drug that you know well, a renin-angiotensin system blocker. So valsartan as an alternative to an ACE inhibitor. And then the new treatment, the new part of this, was the neprilysin inhibitor sacubitril. And we tested this new approach in the Paradigm Heart Failure trial, where we compared sacubitril/valsartan to conventional treatment in both arms of the study. All patients received a renin-angiotensin system blocker. Here it was enalapril, here it was valsartan, but what we were really doing was testing the benefit of adding a neprilysin inhibitor on top of conventional therapy. And as I'm sure you know by now, we showed that this new approach, neprilysin inhibition added to these other therapies, reduced the risk of cardiovascular death or heart failure hospitalization by about 20%, highly statistically significant. But even the very large paradigm heart failure trial left some questions unanswered. And one of them was whether or not we could use sacubitril valsartan in hospitalized patients. There were some other questions as well. So in 2019, a very important second study with sacubitril valsartan was published, and that was the PIONEER heart failure trial. And PIONEER compared sacubitril valsartan once again to enalapril in patients who've been hospitalized with heart failure. There was no run-in period. This was a relatively short-term study because it was considered to be unethical to continue people on long-term enalapril, since we already knew that sacubitril valsartan was superior to enalapril. So beyond the acute phase here, defined as 8 weeks, everybody was switched to open-label sacubitril valsartan. Now, this new study was important because it enrolled more people of African descent. It enrolled people who had no previous history of heart failure, and it enrolled patients who had never been treated with a renin-angiotensin system blocker previously. So those were very important differences from paradigm, in addition, of course, to all of these patients being in hospital with decompensated heart failure. Now, because this study was relatively small and short term, the primary endpoint was reduction in NT-proBNP. We know this is a good surrogate for improving clinical outcomes. And as you can see here, even within just 1 week of starting sacubitril valsartan, there is a reduction in NT-proBNP. And that was seen despite the fact that not all patients had reached the target dose of sacubitril valsartan. Many people had asked about whether or not lower doses than the target dose had some clinical benefit. Well, here is evidence that certainly there was a different pharmacological effect from enalapril, even with lower than target doses. And as you can see here, tolerability was similar to what we saw with enalapril, except of course, as expected, there was a little bit more hypotension. But what was really important about this study was that even though it was only 8 weeks, 56 days, you can see that there was a reduction in this predefined clinical composite outcome, mainly reduction in heart failure readmissions, but nevertheless a striking, early and statistically significant benefit with sacubitril valsartan compared to enalapril in hospitalized patients. So really that led to some of the newer guidelines considering sacubitril valsartan as one of our foundational therapies for heart failure with reduced ejection fractions. So no longer just a RAS blocker, beta blocker, and an MRA, but preferentially sacubitril valsartan plus a beta blocker plus an MRA. Remembering, of course, this is 2 different pharmacological approaches combined in a single pill. And I'm sure you're familiar with this story, but if you want to read more about it, there is a whole edition of JACC Heart Failure late last year, dedicated to the 5-year anniversary of approval of sacubitril/valsartan in the United States. And there is a review of really everything that we've learned in the 5 years in this issue. So now I want to fast forward and spend most of the time today talking about the more recent developments. And I'm going to focus on the past year because incredibly, we've had 4 positive trials reports in patients with heart failure and reduced ejection fraction, at least trials in ambulatory or outpatients with HFrEF. There have even been additional studies that have enrolled hospitalized patients. So I'm going to focus on the past 12 months, and I'm going to start with DAPA-HF, published in 2019, and EMPEROR, published last year in 2020. And this is really my second theme, which is that we not only moved forward from neurohumoral blockade, but now we've even moved forward from neurohumoral modulation, because these 2 trials were about SGLT2 inhibitors. We do not believe these drugs have anything to do with neurohumoral pathways. In fact, the only place we know that you find SGLT2 for sure is in the proximal renal tubule. And as you know, these drugs were introduced as glucose-lowering treatments for patients with type 2 diabetes. But we now also know that they're much more than that. They really are revolutionary treatments. They have revolutionized the treatment of heart failure, which I will talk about, but they have just as importantly revolutionized the treatment of chronic kidney disease. They're in fact the first ever drugs to reduce the risk of death in patients with chronic kidney disease. And of course, they're still a treatment for type 2 diabetes. So these now have become, they remind me really of ACE inhibitors, the way their indications have expanded so rapidly across several branches of medicine. But I'm going to focus on heart failure. And amazingly, in just 1 year, we saw these 2 trials in patients with heart failure and reduced ejection fraction, ambulatory patients in the community, outpatients. You can see a summary of the 2 trials here. They're very similar. There are some small differences. EMPEROR-Reduced had different inclusion-exclusion criteria. So the NT-proBNP level was a bit higher, and the left ventricular ejection fraction was a little bit lower, as was the GFR. But essentially, these are pretty similar, very like all of our previous trials. What's even more important is that in these 2 trials in ambulatory HFrEF patients, I'll remind you, with and without type 2 diabetes, so these were heart failure trials, not diabetes trials. In both of these trials, there was an almost identical treatment effect on an almost identical endpoint. In DAPA-HF, our endpoint was cardiovascular death or worsening heart failure, but in fact, this was mainly heart failure hospitalization. So these 2 endpoints were more or less the same. You can see the reduction in the primary endpoint was almost identical, 26%, 25%, highly statistically significant in both trials, small number needed to treat, and very importantly, if you look at the Kaplan-Meier curves in both trials, there's very early separation. In DAPA-HF, we saw a significant and sustained benefit beyond the first 28 days. So within 1 month of starting treatment, there's a significant reduction in events. And exactly the same thing was seen in the EMPEROR-Reduced study. So this is very powerful evidence, 2 independent trials, 2 different drugs within the same class, but an entirely consistent treatment benefit. And crucially, this benefit was exactly the same in patients without type 2 diabetes as it was in patients with type 2 diabetes. The relative risk reduction here, 25% relative risk reduction in heart failure hospitalization or cardiovascular death, patients without diabetes, exactly the same as in patients with diabetes. So this is a new class of treatment for patients with heart failure and reduced ejection fraction. It's not about diabetes, it's about a new class of treatment for patients with heart failure and ejection fraction. And in both trials, I'm just showing you, DAPA-HF in this slide. In both trials, that benefit was really completely consistent across all the different subgroups that we looked at. That's also an extremely important point. Now, in the interest of time, I'm going to skip another very important finding, but I just can't fit everything in the time allocated. So I'm not going to show you the data, but there are strong data from both of those trials that not only do we stop people being admitted to hospital, not only do we increase survival, but we also make people feel better, and we also reduce the risk of deterioration, whether you assess that using NYHA class, the doctor's assessment, or whether you rely on a patient-reported outcome, for example, the Kansas City Cardiomyopathy Questionnaire. Both trials showed very substantial benefits in terms of symptoms and quality of life. So these treatments really tick all the boxes. They achieve all the goals of treatment in HFrEF. And in addition to that, these drugs have other important benefits. And one of them relates to this close intersection between heart failure and kidney failure. We know that many of our patients with heart failure go on to develop chronic renal impairment. And of course, when your kidneys don't work, that seems to be associated with worsening heart failure symptoms and worse heart failure outcomes. And again, if you look at the two trials together, they had pre-specified renal endpoints, and together the trials showed a substantial reduction in worsening kidney function. And you can see that here in the two trials if you look at decline in eGFR time. So both of these figures show you the GFR slope. So we know obviously in patients with heart failure, kidney function decreases over time. But in patients who get an SGLT2 inhibitor, the rate of decline in the eGFR is reduced, is slowed. And in fact, very similar change in both studies. Very, very important because, of course, declining kidney function is a major problem for us in the management of patients with HFrEF. Often makes it difficult to use renin-angiotensin system blockers, mineralocorticoid receptor antagonists. Sometimes we even have to stop those drugs because of decreasing kidney function. These drugs slow the rate of decline in renal function in patients with HFrEF. And again, I want to emphasize the consistency of this story. This is very strong evidence. These drugs will get a class 1 level A recommendation in new guidelines because of the strength of this evidence from these trials. And we just published just in the past couple of weeks, in fact, another benefit of this type of treatment. So in DAPA-HF, when we looked at the patients who did not have heart failure, did not have type 2 diabetes at baseline, so 55% of patients in DAPA-HF did not have type 2 diabetes. And when we followed them up over time, so here's 2 years, you can see in the placebo group, about 10% of these patients went on to develop type 2 diabetes, but that risk was reduced by about 30% in the patients who were randomized to dapagliflozin. So these treatments have the additional benefit of reducing the risk of developing type 2 diabetes. And if you've got heart failure, you really do not want to develop type 2 diabetes. Now, again, I can't spend the whole time talking about the incredible findings with these drugs. Here are the publications we've written from DAPA-HF. There are publications now coming out from the EMPEROR-Reduced trial. If you're interested, I think all of these are free to download. You do not have to have a journal subscription. We've tried to make these free to anybody who wants to access them. So there's a lot more that you can read if you're interested. So I want to put these findings into perspective. So I mentioned Paradigm. That was our last big breakthrough back in 2014. And here you can see the hazard ratio for the most commonly used composite endpoint, cardiovascular death or heart failure hospitalization, 20% relative risk reduction. And for all the other things that we commonly look at, the bottom row shows you the findings from DAPA-HF just for comparison. And this is really to make the point that the benefit of SGLT2 inhibitors is really at least as large as the benefit of neprilysin inhibition. I'm not saying these two treatments are in competition. They're not. I will come back to that later. I'm just trying to illustrate that they both have really large additional treatment benefits over and above a RAS blocker, beta blocker, and mineralocorticoid receptor antagonists. But what is really important is that the vast majority of our patients with HFrEF are eligible potentially for treatment with an SGLT2 inhibitor. Here is an analysis from the US with the guidelines heart failure registry, and the investigators looked at the FDA approved labeling for dapagliflozin, and they reckoned that about 4 out of 5, that is around 80% of patients in this large real-world registry would be eligible for treatment with an SGLT2 inhibitor. So this is a new type of treatment that could really help the majority of our patients with HFrEF. Now, there still are some outstanding questions, and these are the 3 questions I get asked most about SGLT2 inhibitors, about acute heart failure patients who are in hospital, about preserved ejection fraction, and maybe the hardest question of all is, how do these drugs actually work? How do they have all of these benefits? So let's very quickly look at those. And let's say something about acute heart failure, because we now have an answer to that question. And we have that answer from a trial called SOLOIST Worsening Heart Failure. This used a drug called Sotagliflozin. It actually blocks SGLT1 as well as SGLT2, but it is a much more potent inhibitor of SGLT2. Sotagliflozin was studied in a trial of patients who'd been hospitalized with worsening heart failure, so critically important. These were not ambulatory patients. These were patients in hospital. In this trial, they all had type 2 diabetes, so that was different from DAPA-HF and EMPEROR-Reduced. And very interesting, in this trial also, some of the patients had heart failure with preserved ejection fraction, as well as heart failure with reduced ejection fraction. Again, these patients differed a little bit from the other 2 trials. Obviously, more of them were in NYHA class 3 or 4 because they were in hospital, or they could be randomized within 72 hours, within 3 days of discharge. They obviously had a high NT-proBNP because they'd just been hospitalized, and they had a substantially lower average glomerular filtration rate than in DAPA-HF and EMPEROR-Reduced. But the result was just the same. Now, this is a slightly different endpoint, but the message is exactly the same. This very early separation of the event curves, this striking reduction in events, highly statistically significant. And in fact, this trial had a very short-term follow-up, and yet over a median of just 9 months, you can see this huge benefit. Now, the important point of this trial is shown on this slide. This is the subgroup analysis. I said patients could be enrolled in hospital, randomized in hospital, so treatment started before discharge, or treatment could be started within 72 hours, 3 days of leaving hospital. But as you can see here, the treatment effect was exactly the same as the overall treatment effect. So this is now evidence that drugs of this type are beneficial in patients hospitalized with heart failure. You can use them in hospital, or you can use them in the community. We've recently published an updated meta-analysis now putting all 3 of these trials together, and you can see here this very consistent large reduction in events. Again, very powerful evidence. This once more will be undoubtedly a class 1 level A recommendation in the new guidelines because of the consistent evidence from 3 separate trials with 3 different drugs. But soloist worsening heart failure is very, very important for another reason. And the other reason is it tells us a lot about tolerability and safety. Interestingly, in this trial, there was one adverse effect that we've not seen with DAPA or empagliflozin, and that was diarrhea. There was an excess of diarrhea. Not many people got it, but there was some more, and that's because of the SGLT2/1 inhibition. But the reason that soloist worsening heart failure is so important is because it really tells us a lot about the risk of ketoacidosis, because we know that it is patients with type 2 diabetes who get ketoacidosis, and all the patients in this particular trial had type 2 diabetes. And our endocrinology colleagues always tell us that it is patients who are sick, admitted to hospital, who may also be at more risk of developing ketoacidosis. So this is what in the UK, in our way of speaking English, we would describe as a canary in the coal mine test of safety. And here you can see all 3 of these trials put together, and really the incidence of ketoacidosis is very small. There is no excess with SGLT2 inhibitors overall. And in DAPA-HF and EMPEROR-Reduced, there were no cases in patients without type 2 diabetes. So this is a problem in patients with type 2 diabetes, but it is very uncommon overall. And in fact, again, to give you context, if you look at the risk of angioedema with an ACE inhibitor or with an neprilysin inhibitor, in fact, the risk of angioedema is probably slightly higher than the risk of ketoacidosis with an SGLT2 inhibitor. So although this is often talked about, I think it is, and the concern is exaggerated. What about heart failure with preserved ejection fraction? Well, as I mentioned, this trial also included a small number of people with an ejection fraction of 50% or above. They seem to get just as large a benefit. And more importantly, this group of investigators in their sister trial in patients with chronic kidney disease also documented the presence of heart failure with preserved ejection fraction in this trial as well. So between the two trials, there were over 700 patients with heart failure and preserved ejection fraction. And as you can see, again, the very strong suggestion that this type of treatment is beneficial even in patients with heart failure with preserved ejection fraction. Now, these are subgroup analyses. We have to wait for the two definitive, dedicated, prospective HFpEF trials, each with about 6,000 patients, EMPEROR preserved and DELIVER, EMPEROR preserved with empagliflozin, DELIVER with dapagliflozin. EMPEROR preserved will present later this year. So we will see the results of the first large HFpEF trial in the next few months. And the last question about this new class of drugs is how do they work? The simple answer is we really do not know. There's lots of speculation. I've written articles, other people have written articles, everybody speculates about things like improving myocardial metabolism, maybe affecting other important ion channels in the heart. Maybe it's just about protecting the kidney. Maybe it's because these drugs, at least initially, at the start, have an early diuretic effect, but we really don't know. But there is some really interesting and surprising new evidence that's just come out in the past few weeks. This is a study we did using cardiac magnetic resonance imaging in patients with HFrEF who had diabetes or pre-diabetes. This was a 9-month, a 36-week study. You can see that we found that empagliflozin led to a reduction in left ventricular end systolic and end diastolic volume. There was a trend to reduction in left atrial volume, but not significant. Trend to a greater increase in LVF, but again, not significant. Some colleagues in New York did a very similar study, but this time 6 months follow-up, and their study was in patients without type 2 diabetes. And in this study, empagliflozin reduced end diastolic and end systolic volume, so this is the same as we found, but they actually also saw a significant increase in left ventricular ejection fraction. And again, just in the past couple of weeks, a study from Denmark. This is an echocardiographic study, very short-term study, only 12 weeks follow-up, and yet in this study, once again, reduction in left ventricular volumes, a reduction in left atrial volume, and once more, a trend to improvement in ejection fraction, although this was not statistically significant. But again, 3 studies now showing favorable left ventricular remodeling with an SGLT2 inhibitor. So somehow these drugs are having a beneficial effect on the heart. And of course, that's entirely consistent with the clinical benefits that we've looked at. So that's one of the breakthroughs in the past 12 months. There are 2 more. I'm not going to say as much about them. One is was shown in a trial called Victoria. Victoria was a trial that used a drug called vericiguat. Vericiguat is a stimulator of this intracellular enzyme called soluble guanylate cyclase. If you stimulate this enzyme, you increase production of intracellular cyclic GMP. And cyclic GMP has a number of actions in cells that we think might be beneficial in patients with heart failure. Now, this pathway overlaps a bit with neprilysin inhibition because, of course, natriuretic peptides also stimulate intracellular cyclic GMP by acting on a different form of guanylate cyclase, particulate guanylate cyclase. So the Victoria trial enrolled a different population than most HFrEF studies. These were really high-risk patients because they were either in hospital in a few cases or had very recently been hospitalized. They also had to have a very high NT-proBNP level. And overall, the trial was positive, but the treatment effect was small. At least the relative risk reduction was small. There was only a 10% relative risk reduction, although because these were very high-risk patients, the absolute risk reduction was quite large. This number needed to treat, I think, of only 26. But sadly, the benefit in this trial was really on heart failure hospitalization with no reduction in cardiovascular death. So a relatively small relative risk reduction and benefit primarily on heart failure hospitalization. There have been some follow-up publications in this trial suggesting that there may be an interaction between NT-proBNP level and effective treatment. So it seems to be more effective in patients with lower NT-proBNP levels. And in keeping with that, it also seems to be more effective in people who are a longer time after discharge from hospital. So I'm not sure how we're going to use this drug or how widely it will be used, but it has just about 1 week ago been approved by the US Food and Drug Administration. I think this is the first country where it's been approved. So it'll be interesting to see how we fit this into our new guideline. And then the last of the new treatments, the most recent of those new trials to report in ambulatory patients was the GALACTIC-HF trial using a drug called omecamtiv mecarbil. This drug improves left ventricular systolic performance. It isn't a classical inotrope, but it does improve left ventricular ejection fraction, stroke volume, reduces left ventricular end diastolic and end systolic volume. And we were very hopeful that this trial would be beneficial, and we studied it in a very large trial called GALACTIC-HF. And in this trial, we were willing to enroll patients with a very low blood pressure because this drug doesn't affect blood pressure. We were willing to enroll people with a very low eGFR because this drug does not affect renal function. And we included a quarter of patients as hospitalized patients because we hoped this treatment might be especially useful in patients who were sick in hospital with decompensated heart failure. But again, sadly, although the trial was statistically significant overall, the relative risk reduction was only 8%. And once again, the treatment effects seem to be, at least in the overall population, primarily on worsening heart failure events, as you can see here, with no effect on cardiovascular death. So this was initially very disappointing, I can tell you that, when I saw the results late last year for the first time. But in fact, when we looked at our pre-specified subgroups, one subgroup stood out, and that was the subgroup where we said that we would split ejection fraction, which at the median value, which turned out to be 28%. And you can see here that in patients with an ejection fraction at or below the median value, there was benefit, whereas there was less benefit in patients with a higher ejection fraction. And this was a highly statistically significant interaction. You rarely see an interaction between a baseline variable, in this case ejection fraction, and the effect of therapy, you rarely see an interaction that is this statistically significant. So we think there really is something going on here. I think you'll hear more about this in the next few months, because I think there may still be a role for this new drug in patients with a very low ejection fraction. So watch this space. You will see more information in the next. And I don't want to forget one other thing. This wasn't in ambulatory patients. This was in hospitalized patients. Another study reminding us of the importance of iron and iron deficiency in patients with heart failure. We know that treating iron deficiency in ambulatory patients improves symptoms, improves quality of life, increases exercise capacity, but we don't know about the effect of replacing iron in iron deficient patients. We don't know the effect on hospitalization or mortality. The AFFirm-AHF study was designed to look at this question in patients who had been hospitalized with worsening heart failure. Here is the primary composite endpoint. This was a total event endpoint, so all hospital admissions and cardiovascular death. The overall result was a borderline statistical significance, but actually if you look at heart failure hospitalization, you can see there was a reduction. In fact, if you look at the traditional time to first event endpoint, again, there was a nominally statistically significant benefit. So I personally believe that this trial did demonstrate the benefit of intravenous iron in hospitalized patients, and I think that benefit is on heart failure hospitalizations. This trial was too small to look at an effect on cardiovascular death. It was a one-year study. As you can see here, it had only 1,100 patients. It did not have the statistical power to look at cardiovascular death. We'll have to wait on further trials that are currently ongoing to find out about that. So where does that leave us in this early part of 2021? Well, this is, and I'm going to focus on ambulatory patients. This is the amazing position that we're in, because we have now tested 5 different therapies on top of our core treatments, and 4 of these are now approved, at least in some countries. We're still waiting to hear about omecamtiv mecarbil, but going forward, the focus will definitely be on SGLT2 inhibitors and of course neprilysin inhibition, which is already in the guidelines, but I believe the recommendation will be strengthened. And the reason these 2, of course, get more attention than these other therapies is that these 2 reduce mortality. They improve survival, and we put a lot of weight on keeping people alive. So these 5, we now have 5 foundational therapies. They all work in a different way. They affect distinct pathophysiological pathways, but collectively they reduce mortality. Of course, 2 of these can be given in one pill, i.e. sacubitril valsartan. So whether you call them the 5 alive, or as a German colleague of mine recently described them, the Fantastic 4, whatever way you look at it, we're now in a wonderful position to substantially reduce events in our patients. Now, a lot of people ask, do we have to use all of these together? And that's really, do we have to use an SGLT2 inhibitor and an ARNI together, sacubitril valsartan? The answer is yes. So if you look here, these are the patients in EMPEROR-Reduced and in DAPA-HF who were getting sacubitril valsartan at baseline, so they were already getting the benefit of neprilysin inhibition. They had an SGLT2 inhibitor added in half of the cases, and that led to a further reduction in morbidity mortality. In fact, you can see here a 32% relative risk reduction, statistically significant in heart failure hospitalization or cardiovascular death when an SGLT2 inhibitor is added to an neprilysin inhibitor. So all of these drugs work independently. And then the final question, and really the question I would say is the one that we will debate most of all in the first half of this year, is how do we use these drugs? What order should we prescribe them in? And I'm going to finish by arguing with you that this traditional approach might no longer be the right one, might be out of date and old-fashioned. And you know what I mean, this stepwise approach where you start with an ACE inhibitor, you titrate to full dose, you add a beta blocker, titrate to full dose, add mineralocorticoid receptor antagonist, and so on. This takes a long time. And the fundamental flaw with this is that it assumes that the most effective and well-tolerated treatments we had were developed first, because why else would you start with an ACE inhibitor? But in fact, it is not the case that an ACE inhibitor is the most effective. It's probably not the best tolerated of the treatments we have either. And we've got to think differently. We've got to think about all of these drugs working in a different way. They work independently of each other. They all reduce mortality. They are complementary. They're additive. And the goal should be to implement as many of these treatments as possible, as quickly as possible. We know, in fact, that they all have a benefit within 30 days. So each of these has been shown to reduce morbidity and mortality within 1 month of being started. So that really says to us we should be trying to start them all together as quickly as possible. And I would argue that the order in which we prescribe these treatments should depend not on which was used first in our clinical trials, but on the speed of onset and size of benefit. And really, I think in 2021, what we're trying to do is to point out the urgency of getting these patients on this life-saving cocktail of drugs. We all know that the diagnosis and treatment of cancer is urgent, but why is that not the case for heart failure? Because our patients with heart failure have as poor a prognosis as patients with most forms of cancer, and they deserve the same urgent approach. So when we think about the sequence, the order in which we use these drugs, we should think about these things. And very recently, myself and Milton Packer published a paper in Circulation, really to challenge people to think differently about what we do. And in fact, we put forward an approach to using treatment whereby we thought that we could get all 4 treatments started within 4 weeks. Obviously, people will not be up titrated to the full dose of each of these drugs, but we thought it would be possible using this approach to get people on these treatments very quickly. I'm not saying this is going to be suitable for everybody. We could debate the order, especially I would say of the second and third step in this algorithm, but we weren't really showing this to say how it should be done. It was to provoke debate and discussion and to challenge people to think about how we can do this more quickly, because the sooner we get these treatments started, the more benefit our patients will get. So to summarize and conclude, we have really lived through the most amazing times in recent years in heart failure. We're continuing to study new drugs and new mechanisms. who would have thought in just the past 5 or 6 years we would have 2 new life-saving treatments, and in addition to that, 2 more new drugs, completely novel molecules that at least reduce heart failure hospitalization. We've also got the new evidence for intravenous ARNI. And for us going forward, it's not whether we've got effective treatment. We've got lots of effective treatments. The challenge for us going forward is to make sure that our patients get these treatments. The challenge is their implementation. Thank you very much.
Thank you so much, Dr. McMurray, for such an excellent conference. We have some questions. The first is from one of our imaging cardiologists. Do you think the presence and amount of late gadolinium enhancement in CMR may help guide medical treatment in heart failure with reduced ejection fraction?
Well, so the answer is it might, but I don't think that we know. So if you know me, you know that my approach to everything is to do a randomized trial to prove that something is worthwhile. And in fact, there are a number of randomized trials underway looking at exactly this question. So, for example, there's a lot of discussion about whether ICDs, for example, could be better targeted to patients who have a lot of late DADs, because they may be patients who are at more risk of ventricular arrhythmias, sudden death. So yes, maybe it could be useful. We have to come out with the evidence. You have to prove that, and I think I would prefer to wait for the results of some of the ongoing trials before changing practice.
Thank you.
Thank you, Doctor. We have another question. Having into account the results of the sub-analysis of the EMPEROR and DAPA and the relation with ARNI and ISBLT2, do you think we have to change the background therapy of all our heart failure patients with reduced ejection fraction?
So I'm not sure I quite understood that. The reason I'm saying that is when you say change the background therapy, do you mean change existing drugs, or do you mean add an SGLT?
For example, if we have a patient with an ACE inhibitor, we have to change this patient to an ARNI plus ISGLT2?
Well, if you want to give your patient the best chance of staying alive and staying out of hospital, then the answer is yes. The benefit of those 2 new drugs, an epilystin inhibitor and an SGLT2 inhibitor, is really very, very large, and will make a very big difference for patients. So in an ideal world, and I realize we don't live in an ideal world, if your patient has access to those drugs and tolerates them, then the answer is definitely yes, from a purely evidence point of view.
Thank you very much.
There's another question. Will it be possible to check the neprilysin inhibitor effects alone, combined with anti-aldosteronic therapy in a single pill, making an approach to the anti-proliferative properties of the last treatment in heart failure?
So that's a very good question. So one of the, again, in the interest of times, one of the things I had to skip over was that it took us, as I said, 25 years to discover how to use an epilyssin inhibitor safely. And part of that 25 years included finding out that combining an epilyssin inhibitor and an ACE inhibitor is not safe. There is a significant risk of angioedema. So that's why sacubitril valsartan, that's why the 2 drugs were put in 1 pill. That is why an epilyssin inhibitor was not developed as a single therapy by itself. If neprilysin inhibition had been developed in combination with mineralocorticoid receptor antagonists, the danger would have been that that combined pill was given to somebody taking an ACE inhibitor, and that patient then would be at risk of serious life-threatening angioedema, because sadly we did that trial many years ago now with a drug called omapatrolat, which was a combined neprilysin ACE inhibitor compared to enalapril. And unfortunately, we found that there was a significant increase in risk of angioedema, which sometimes led to patients requiring a tracheostomy, and sometimes, in fact, patients died. So you cannot safely combine neprilysin inhibition with ACE inhibition. That's why the safest way to develop neprilysin inhibition was in conjunction with an ARB, and then people wouldn't run the risk of accidentally giving a neprilysin inhibitor in combination with ACE.
Okay, thank you very much. Doctor, as you just said, probably we have to change the way we see the heart failure guidelines. I mean, we have to change the vertical way to, in a way, and we can use the first 4 molecules at the first time. So, like the wave of the 4 fantastics. So, are you okay with that? I mean, in the first time we see a patient in the hospitalization room.
Yes, I'm very okay with it. I would have said a few years ago I was not, but I've thought about it a lot. I've analyzed a lot of data, and I'm very comfortable with there being better ways to do it than we currently are. In fact, I hope to publish a paper shortly to actually show that some of these new sequences would actually save considerably more lives and reduce many more hospital admissions than our conventional approach. So I'm comfortable in doing it from a evidence point of view, from a scientific point of view, and I'm comfortable doing it from my own recent personal experience of doing it in my own patients, because it is very, very easy to do some of the things that we've described. SGLT2 inhibitors, if you've used them already, you will know that they have no effect really on blood pressure, don't really have any effect on kidney function, don't affect potassium, extremely well tolerated, no dose titration, 1 dose for everybody, that's it. So that makes it very easy then to add a second drug. The reason in our algorithm we suggested a beta blocker is beta blockers have by far the largest mortality benefit. And again, they don't require laboratory monitoring. So again, makes some sense to use those. And, you know, you could debate about whether it's an MRA next or whether it's sacubitril/valsartan next. You will maybe have seen, I didn't again have time to discuss it, but there is a new American college document, consensus document, just published in JACC. And I was very, very pleased to see that that document has a lot of fresh thinking about how to use treatments in heart failure. And in fact, in that document, they even suggest, like we did in our algorithm, that in some patients you could even start 2 treatments at once to again get these life-saving treatments started as quickly as possible. Now, of course, it's not the same for everybody. It's much easier in a de novo patient, a newly presenting patient, to start drugs. They have higher blood pressure, they have better kidney function. It's easier probably in an ambulatory patient than in a hospitalized patient. So of course, the way you do this requires clinical judgment and your clinical skills that you've learned, and you need to take account of the patient's situation, characteristics, blood pressure, kidney function, and so on. But I think that we all know we probably know how to do this, and we've probably all been beginning to do it anyway for several years, because none of us follow the very slow up titration that was done in the clinical trials. I mean, I don't know if you know, but in the clinical trials, some of them had 8 titration steps for beta blockers. I don't know if you do that, but I really think those are historical, what we would call legacy in English. They're a hangover from the days when we were worried about, for example, using beta blockers in heart failure. I don't think we have the same concerns today. So I think we just have to update our practice and try and do the best thing we can for our patients. And it's probably no longer to take the traditional approach. At least that's what I think.
And I think the last question, I'm going to read it just like it says. Do you think the treatment of heart failure will possibly be guided through neuro-humoral profile and intermediate range and possibly in preserved ejection fraction in the near future?
That's a great question. I mean, that could be a whole different lecture. I think maybe what's more likely is that we will redefine what we mean by heart failure with mid-range or mildly reduced ejection fraction. So that may be an ejection fraction from 40% to perhaps 55 or even 60%, maybe more higher in a woman than a man. I think preserved, what we used to mean by preserved ejection fraction, I think that's now not a very helpful term. I think if you're talking about people who've got a completely normal ejection fraction, that is a different disease. But I think in people who've got an ejection fraction that is below normal, but not as low as HFrEF, so not 40, but still not normal, so 50, 55%. Those people probably have systolic dysfunction. I think certainly if they've got elevated natriuretic peptides, that's telling you there's something wrong with their heart. And I think if your ejection fraction's in that below normal range, and you've got elevated natriuretic peptides, then probably you get some benefit from all the drugs that we've talked about. Maybe not as much as if your ejection fraction is 35%, but I think you probably do get some benefit.
Well, thank you very much, Dr. McMurray, for this excellent time. Thank you. Thank you. It was an amazing time, and thank you for sharing us with us all your knowledge. Thank you very much.
Thank you for the invitation, and apologies for not being able to speak Spanish. No,
don't worry. Hope we can see you soon.
See you here.
And here too. Thank you very much.
Okay. Thank you. Bye-bye.
Muchas gracias a todos por acompañarnos hoy. Gracias a todos los que estuvieron acá muy activos con su participación. Se los agradecemos enormemente. Estaremos enviando nuevas invitaciones. Muchas gracias.